Hello, I'm Ileana Piña from Jefferson University in Philadelphia. I am the quality chief for the cardiovascular line in the Division of Cardiology. I am thrilled to have my good friend Dr. Stefan Anker, who is a clinical trialist par excellence in Berlin at Charité Hospital, which, by the way, puts in more devices than anybody else in Europe. So you are going to be presenting the FAIR-HF2, having done the FAIR-HF1, maybe not you, but you and your colleagues. What is different about the HF1 and the HF2? What are the differences?
Well,
this is iron therapy, by the way.
Yes, intravenous iron therapy. Thanks for asking, giving me the chance here to present. FAIR-HF2 is basically an events study. FAIR-HF.
So it's event-driven.
Event-driven, or shall we say, aiming to look for events with as many patients as we could recruit with the given budget, with the given time and all of this. So we were aiming between 1,000 and 1,200 patients. In the end, we had 1,105.
That's pretty close.
The original FAIR-HF1 trial was 459 patients, 2-to-1 randomized, and was aiming to look for symptoms and quality of life and patient global assessment of well-being. And it was only for 6 months.
Right, it's short term.
Now we are talking 1 year and 9 months average duration of follow-up. And also what is different is the way we are giving the drug. It's the same drug, ferric carboxymaltose, but in the original trial we were basically in the first 5 weeks giving 5 times 200 milligram because we were using the original dosaging from the previous versions of iron. Now, of course, the modern irons, you can give 1,000 milligram in one session, and you can give up to 2,000 milligram with...
easier for the patients.
Oh, yes, less visits, etc.
Yeah.
So we're basically giving 1,000 milligram, and then in some patients an extra 500 or 1,000 in a second session. So we are basically giving now also more iron. And in our trial, we were hoping to give a higher dosage of iron than in other events trial that reported, that previously said between 300 and 500 milligram per year than in the second and third year. In our trial in year 2, we managed 900 milligram. In the third year, 700. Still, if you then in the end look at the results, we maybe should have even gone higher.
What would you say to your patients about giving them iron? We will have to repeat it in a year. We'll have to repeat it in 9 months.
And what we are in our clinical practice doing is every 4 to 6 months. So in the trial, actually every 4 months, we were repeating, giving a small amount of iron, 500 milligram. Maybe in the future, we could say we should aim for anywhere between 2,000 and 3,000 milligram in a year, depending on the frame size of the patient. A smaller patient, maybe a little less. Patient with a hemoglobin value that is normal, maybe a little less. But then those that are iron deficient and really have anemia, those that are a little bit bigger, then maybe it's more like the 2,500, 3,000 milligram.
Did you make a difference by sex?
We actually did not, except that, of course, for the inclusion, we had for the patients a different kind of set for the hemoglobin value for anemia and non-anemia.
Right.
But otherwise, but for the dosing itself, we didn't make a difference.
Okay. So what did you find?
Well, basically, we had 3 primary endpoints. We were looking for the first primary endpoint being cardiovascular death and heart failure hospitalization, time to first event.
Our standard
21% reduced. Now, 21% reduced sounds good. The problem is the 1,100 patients. So the p-value is actually 0.038. Now, that sounds significant and is technically significant.
Yeah, technically it is.
The problem is we had 3 primary endpoints. We should have had 0.0167. So on this technicality, I should officially say...
statistically significant.
Formally speaking, it isn't. Yeah. No. We had a second primary endpoint with recurrent heart failure hospitalizations, 20% reduced, but also p-value is 0.1. And the third primary endpoint, now that's a bit of an interesting one. I should say 1 or 2 things in the background. The definition of iron deficiency, where you use a low ferritin, or when the ferritin is not quite so low, you use a low TSAT.
The TSAT.
There has been a discussion that we should only use a low TSAT. So we had a third primary endpoint for the subgroup of patients with TSAT less than 20% for CV death and heart failure hospitalization. And you know what? Also 21% reduction. no different than those
Didn't make any difference.
So I can take two spins on this kind of conclusion. Our original definition of iron deficiency is okay. But for those for whom it is too complicated or maybe a little bit too costly, because ferritin assessment is more expensive than TSAT assessment, using a TSAT less than 20 is also okay.
It's a good okay to do.
That's a clinical conclusion that we have now a prospectively tested second definition of iron deficiency.
Certainly may be easier for even the primary cares to take a look at the numbers.
Sure. When you do a blood count, you get this essentially automatically. But it remains that, technically speaking, we didn't quite make the significance. And now it depends on whether you take the totality of evidence approach or you are basically focusing on the individual trial. This trial having gone through the COVID period, this trial having lasted 7 years. Long-term intravenous therapies in a double-blind setting, it's probably more difficult than we originally anticipated to keep people engaged to participate in the trials.
Yeah, people start falling.
So there's attrition, basically.
Yeah.
To prove our argument that those results are in line with the previous trials, we actually did a new meta-analysis.
Okay.
So the FHF2 is published in JAMA.
Right.
And the second paper we have coming out is in Nature Medicine on the meta-analysis.
What did you include in the meta-analysis?
Well, all the big 6 trials with at least 6 months follow-up.
Ironman, you put Ironman.
Yeah. Ironman, there is the HeartFit trial, there is the Affirm HF trial.
Oh, good, okay.
There's the Confirm HF and the also the original
So
FHF
how many
trial.
patients that end up being?
7,175.
Yeah, which you're never going to get in one trial alone.
So now we're talking 20% benefit and highly significant. And that's for the totality of follow-up time. And what we pre-specified in the meta-analysis also to look at the first year alone. That's where we give the highest dose of iron. And so in the highest
more patients.
Well, of course also more patients. Yes, of course. So for the combined endpoint, CV death and heart failure hospitalization as recurrent events, 22% reduction. If you really only focus on heart failure hospitalizations in the first year, 28% reduction.
Now, did you include heart failure equivalents like, extra diuretic?
No.
It's so hard to do that because everybody practices it in Europe. What you guys do is different than what we do, so it's really difficult.
Well, there's one good news about this meta-analysis. For 5 of the 6 trials, we had access to the database.
So you have the real numbers.
Not for all, for 5 of the 6. So the 5 trials were modeled to the analysis of the Ironman trial. Statistically, exactly the same methodology, using the same boundaries also for the subgroup analysis. And so we actually, in a valid way, can even talk about the subgroups. So we had 8 subgroups, ischemia not, anemia not, TSAT not, all of that, no significant difference. But men versus women. There's a significant difference. Can't explain it at this moment.
What is the difference?
Well, in women, you don't get event benefit.
Interesting.
In men, you do in a very significant way. It's a highly...
The age is different between the men and the women? Or
this is probably something we need to now explore all the possible reasons. The women may have received slightly less iron because their body weight is lower.
Or if they're younger...
I don't think they were much younger,
but
we need to look. We need to look. The hormone issues could play a role. Do they have a different responsiveness to the iron that they received? All of these things are now big question marks.
But they're fascinating questions.
Oh yeah, I mean it's honestly for the first time I publicly advertise in a very strong way. We need to have some gender-focused research here. Yeah,
You've improved. I'm so proud of you.
No, it's really I think we need to have for your audience say that basically the FHF2 trial was an investigator-initiated trial. The legal sponsor is actually with a German university, which is not mine, but in Hamburg. And I have a second co-PI, which was Maya Karakas.
It's an academic study, and it's one of those things that we're learning from.
I mean, we had government money. We had some co-funding also from the industry, but they totally stayed out of...
That's even cleaner and better. Wonderful. Congratulations. This is good work. We look forward to all the subgroup analysis you're going to do.
Okay.
And I want to thank you, Stefan, for joining me today.
Thank you.
And for our audience, you need to think about iron. So when you look at the patients and you're doing all your demographics, please don't ignore the iron levels. Look at the TSAT. Look at the ferritin. The heart failure patients have high ferritins. This ferritin is an inflammatory marker, and so it's hard to differentiate. But now we know that TSAT will work for them to do that. And then think of the IV iron. It's generally pretty well tolerated. We use it a lot. We've become very accustomed to doing that as well. So until the next time, from the ACC in Chicago, I say farewell. Have a good evening.